And my goal for us over this time is just to evaluate the acceptance of vomiting in cats. I think over the decades or the millennia of people having cats, they just kind of accepted that they're vomiters. And it doesn't have to be the case. Cats shouldn't vomit, just like people shouldn't vomit. If you think about seeing the vomiting cat, once a week, and people think, it's normal. I wouldn't want to vomit once a week. So we shouldn't let our patients vomit that frequently either. Just a brief outline of what we're going to go through, just basic anatomy, I promise, nothing too hardcore. A little bit of some historical things that might be helpful, some of the differentials, environment, some diagnostics, in some cases. So just a quick quiz question. Which answer best describes your initial thought when you see vomits, hairballs in an appointment history? Not necessarily why they're there, but you just see it in the history. A, that's a normal cat behavior. B, that's not normal. Or C, you just ignore it. All right. So 42%, that's normal cat behavior. 56%, that's not normal. And then 2%, we ignore it. Let's get rid of that. We all know what the vomiting cat looks like. This is the typical hairball.
Ew!
And fortunately, we're coming to the conclusions now after years and years of accepting cats do this, that this is not. So even if you see in the history that this cat's vomited hairballs for 5 years, although it might be common for this cat, technically, we need to start considering this as abnormal. This is just my basic anatomy of the upper GI tract in cats. So the liver, gallbladder, upper small intestine, so the duodenum here, and then this fun ampulla of Vater is where that common bile duct and the pancreatic duct meet to empty into the papilla, the major duodenal papilla in the duodenum of the cat. So you can see how if there's any disease of this little area around the duodenum, how easily it can go up into the gallbladder and down into the pancreas. Anatomy on the ultrasound, just so the piece of small intestine, if we're looking at it as a cross-section end on, with the ultrasound, right in the middle where the lumen is that white layer. And then we have mucosa. Submucosa muscularis is this black line. This is submucosa, mucosa muscularis right here. And then there's a little thin kind of white covering on the outside, and that is the serosa. To go over just basic GI terminology, we classify chronic enteropathy as 3+ weeks of having gastrointestinal signs. We usually classify them by how they respond or what they respond to. So we have a chronic enteropathy that is steroid responsive, or we have an antibiotic responsive chronic enteropathy, food responsive, or an immunosuppressive responsive chronic enteropathy. There's also neoplastic, and then triaditis is kind of a whole nother topic involving cholangiohepatitis, pancreatitis, and chronic enteropathy. The history is really important. So we need to know, is this chronic? Is this acute? So is that the three weeks plus, or is this that happened today? What are they vomiting? Is it food, hair, clear liquid, foamy, clear liquid, or are we seeing bile, that green, yellow fluid? When do they vomit? Is this a regurg? So did they eat the food and then just kind of turn their head and bleh, it comes out? Or are they actually doing the vomiting where there's pressure and they're gagging and retching? Or is this like a delayed emptying issue where they're eating their food, it sits in their stomach, and then 8 hours later they're vomiting it out? So is it immediate or is it 8 hours later? Um, when do they vomit associated with things like hypoglycemia and food access? This can be a bilious vomiting syndrome issue too. So are they going all night without eating and then vomiting at 5 a.m. before their food is coming? Um, are they meal fed? Are they free fed? Do they try to eat and then walk away? A lot of times I get that pattern with cats that have something like pancreatitis or abdominal pain. So they're hungry, but they go to the food bowl, they sniff it or they take a bite, and then they just kind of walk away like, nope, that does not feel good. Have there been environmental changes? Has there been new people? I always say new furniture. Could be something as simple if they're stress related as they brought in some new furniture and that stressed the cat out. There's new smells, new people going on vacation, being out of town, taking the cat on vacation. I think stress is an under recognized cause that we need to investigate for vomiting. Are they already on medication that is ineffective? If this cat is on Serenia already for vomiting and they're vomiting through that, I am red alert sign. This is bad. Obviously, the physical exam is really important too. You need to know the muscle and body condition score so you can track it. Um, in when you're palpating the abdomen, are you noticing pain, splinting? Sometimes if you have a real stoic cat, they don't do anything. You can watch their pupils or have the nurse do it. So feel all over their body if nothing's happening, and then you start palpating their cranial abdomen and you have the nurse look at their eyes and their pupils all of a sudden are dilating and constricting when you're palpating their abdomen. There's probably some pain response there. Or you can listen to their heart rate with one hand and then try to palpate their abdomen with the other. It's a little difficult, but you can do it and hear their heart rate spike. You might feel a mass. There might be some severe intestinal thickening that you can actually palpate, or you might feel the liver poking out from underneath their ribs further than it should, and the large spleen, mass, that type of thing. Are we seeing jaundice? Are we seeing dehydration? And then what's their neurological status? Those bottom three are going to give you some idea of how urgent this is and how quickly we need to jump on this. When we're talking about pain in cats, you can use the feline grimace scale. We use it in our hospital. You can download the app. You can use it. Nurses can use it. The technicians. You can actually have clients do it too. You just have to guide them a little bit with the muzzle tension and the whisker flare. It might take some practice, but that's something that they can use and you can use. So here's quiz question 2. Are you comfortable using the grimace scale to monitor a patient's pain? All right. So 42% yes, 21% no, and then 37 aware of it but haven't been using it. That's all right. We can do it. Everybody can use it. It's pretty good tool to have. It's nice to have it on your phone too, because you can use it for post-surgical monitoring and that type of thing. It's a little harder with chronic pain, but if it's like an acute abdominal pain, it is fairly accurate. Now we get into the fun world of the lengthy differential list. I like to put them into 2 separate categories. One is extra alimentary, so all the stuff outside the GI tract, and then alimentary and associated is kind of what I would say. For the extra alimentary, my initial things that I would consider are binge and purge, scarf and barf, medications, electrolyte disturbances, hyperthyroidism, hypercalcemia, infection, kidney disease, neurological issues, and stress. We'll get into the binge and purge and scarf and barf in a minute, but this is a prime example of a binger. And then the alimentary and associated, we have the cholecystitis or cholangitis. This is usually secondary. It's not usually a primary problem. It can happen though. So inflammation of the gallbladder and or the bile ducts. Chronic enteropathy, dietary intolerance. So that would be a food responsive enteropathy or even an allergy. Allergy. Eosinophilic enteritis or the sclerosing fibroplasia that is becoming more recognized. FIP, foreign body, hepatopathy, infectious, which can include bacterial, viral, fungal, some sort of intoxication, lymphoma or other neoplasia, obstipation or constipation, pancreatitis, again, usually secondary, or parasitic, and then GI ulcerations. Where do we start? That kind of depends on the severity of the disease. Um, the the chronic vomiters, you might have some time, but if you all of a sudden see a cat that is acutely vomiting, you might not have much time. So it depends on the severity where you start. Be honest with the owner, that if you do or don't know, if you're thinking, okay, this is going to be complicated, you have got to tell the owner this is going to be complicated. Um, and be honest with yourself too. Don't skip the simple diagnostics. Don't skip the fecal. Don't skip the FELV and FIV test. I know it might seem like, nah, it's not that, but I've been surprised before and I have been embarrassed before. So don't skip the fecal. Don't skip the easy stuff. And then personal bias. Oh, I've seen 15 of these last week and they were all inflammatory bowel disease. So that's probably what this is too. We'll just give it some steroids and be done with it. Also have made that mistake. Um, so try to keep your mind open when you're investigating the causes of these because it might not be what it looks like inside. Client communication is so important to set expectations. You cannot go in and say, I know the problem of your cat's vomiting just by this exam. It's going to work out. This is going to make it all go away. You have to set the expectation that this is probably going to be a trial and error. It might be complicated. We might have to do some things to figure this out, but we don't have to do it all today. Let me give you one thing you can do, one test we can do. Some clients just say, do it all, everything all at once. Is great. That's fantastic. But you need to set expectations for the client to set yourself up for success, set the client up for success, and so they understand they can be empowered to know that there's more things they might need to do. Understand the client's need. Again, I understand that financial issues are there with pretty much every client I see. Everybody wants to know how much things cost, and it's expensive, and I get that. So, do they only have $200 today? Okay, well, here are some things that can fit into that, and maybe they want to save up for something more advanced, in a month. So you have to work with them, figure out what it is they need and expect, and also give them options. We are in the world today of you're not the boss of me. You can't tell me what to do. So in my hands, I have the best luck with saying, okay, this is my ideal plan, but here's another option if you can't do that. I would love to do this $500 blood panel, but I understand that that might not be feasible today. So here's option B or C. And then giving them what comes next. We did this today. If this doesn't work in 3 weeks, call me. Or if this doesn't work in 1 week, this is what we're going to do next. Because if they just say, oh, that didn't work, nothing's going to work. Cannot tell you how many times I've had clients come in and say, we've done everything. They don't know why my cat's vomiting. We've done everything. And I look and they did a fecal and that was it. So, um, so yeah, tell the owner what comes next. That's going to be helpful. And then follow up. Put in a follow up call for a week, 2 weeks. If you're like, this is going to take 6 weeks, put it in for 6 weeks, just so someone calls and to see how they're doing. All right, bilious vomiting syndrome. This one is a little bit of an enigma, but the way it happens is so the cat vomits up that horrible green stuff, the bile that seeps into the stomach from the upper duodenum and causes irritation to the lining of the stomach. Usually the empty stomach. This is where you get the foam, the clear or yellow fluid. And I feel like I see it more commonly in meal-fed cats where their stomach is empty. Um, some treatments for this type of thing, timed feeders that open in the middle of the night might be helpful for this. So late night or early morning meal feed if they are meal fed. Small meals throughout the day, maybe omeprazole. To be honest, I don't really use antacids that much, but omeprazole maybe. But I would bank more on the small meal fed meal feeding first. I would also consider pyloric disease. So why is that pylorus open where this bile can seep into the stomach? The couple of cats that I have done biopsies on that have this issue, they did have either small cell lymphoma or lymphoplasmacytic enteritis. So don't discount it if the easy things aren't working. If they're still getting this weird yellow vomiting, we need to keep going. Behavior. So, if you can hear that. So, behavior, the binge and purge, the scarf and barf. If you can hear that, I wouldn't want to sit next to anybody eating like that. That would drive me bonkers. So, you can see these cats sitting next to each other. Their ears are back. So maybe not so much because he's an orange derpy guy. But all their ears are back. They're sitting right next to each other. They don't like this. Cats don't like to eat like that with all their mouths next to each other like that. So sometimes they will binge their food because they think the one next to them is going to get it. And then they'll go and turn around and barf it up. So binge and purge or scarf and barf, whatever you like, whatever your soup du jour is, you want to say. Usually it's whole kibble, sometimes it's wet food, but I see it most commonly with whole kibble, more common in meal fed versus free feeding, but happens with both. Happens a lot with competition and food anxiety. The best thing to do for this, make feeding stations that are spread out. So this one has one feeding station for 4 cats. I would highly recommend moving these dishes to either opposite sides of the room or around that room so they're not right next to each other and then have them spread out. Most cats prefer to eat alone. Um, there could be other things too that lead to this binging. Other sources of stress. They're seeing cats outside, it's making them stressed out. They have a unpredictable environment, loud noises, things like that. So the list of things that cause stress in cats is infinite. So good luck with that. I love puzzle feeders. I tell everybody that feeds their cat dry food to put them in a puzzle feeder. I give my cats kibble only at night, so they leave me alone, and I put them all in puzzle feeders, so they have to work for their food. There's a website, I should have put it on here. I think it's puzzlefeedersforcats.com or something like that. And it has just tons and tons of different puzzle feeders. There's lick mats for wet food, tons of them on Amazon. They can make them, like this one up here on the right, out of toilet paper rolls and egg cartons. Just something to make them work for it, I think is going to be helpful. All right, quiz question 3. Which of these is not helpful with binge and purge? Puzzle feeders, having cats eat close to one another, or smaller, more frequent meals? Oh, thank you. Puzzle foodpuzzlesforcats.com, someone put in the chat. And no, I do not usually see elevated lymphocyte counts on lymphoplasmacytic enteritis. It's very uncommon. Would I do a PCR or regular fecal? I'd start with a regular fecal. If they also have diarrhea, I would definitely do a diarrhea PCR. Just to answer a couple of those questions. Are the polls coming through? I see a couple people in the chat saying that they're not coming through. Yeah, okay. Okay, good, perfect. Oh, some no, some yes. You have to click the screen. Okay. Maybe someone can chat in the chat to see oh, you need to allow pop-ups from Zoom. Okay. Okay. So hairballs. This is this is my thing. I love to see the look on a client's face when they say, "Oh yeah, she has hairballs once a week, and yay, she's getting those hairballs up. She's puking them up. That's what she's supposed to do." And I say, "Well, actually, they're supposed to poop them out. Cats are not a vomiting species uh, like an owl. They don't puke up their pellet of hair from their prey and leave it for kids to dissect during science camp. uh, Hairballs are not supposed to come out the mouth. They're supposed to come out the butt. So decrease the causes usually decreased gut motility. So there's some sort of chronic enteritis or enteropathy going on, or the ingestion of hair is so much that they cannot pass it. Now, when I say ingestion of hair is high, I mean high. It has to be a lot of hair. It's not just, oh, they're shedding because it's winter. They should be able to pass that. If their abdomen looks like this, okay, they get a pass. They're going to have some hairballs. But if not, or if they have a really bad flea infestation, I've also seen that. I'll give them a pass for a little while. We'll get the skin condition under control, and then we'll reassess the hairball vomiting. But if they have a skin condition and there's tons of hair missing, great. If not, if it's just a little bit of shedding or their long hair. Just because they're long hair does not mean that they can't pass their hair. They should be able to poop that out. So here's my conservative management type of stuff that I do with them. If it's just hairballs, healthy cat, not losing weight. If it's even once a month, I'm kind of like, nah, maybe we need to try something. But if it's weekly, twice a week, more than once a month, we absolutely need to do something. Um, so even I have 5 cats and I have not seen a hairball in, I don't know, a year. So it can be done. So psyllium husk powder is a great one to start with, or you can get VetraScience has furball treats that has fiber in it and give them like 8 of those a day. So start with the psyllium husk powder. You want to start with a little pinch because it's gritty and some wet food, and then gradually work up to an eighth to a quarter teaspoon once or twice a day, depending on what they need. There's Royal Canin has a fiber response diet you can use as a fiber supplement, hairball treats that I said. Increase their wet food. So decrease the dry food, increase the wet. You can even take away the dry food and just do wet food. I've seen a lot of that worked as well. Limited ingredient diets, we'll get into all that too. And then prescription diet trials. So the limited ingredient, there's some over-the-counter ones you can use. My favorite is Instinct limited ingredient rabbit. It's usually my go-to if they absolutely want an over-the-counter one. Some of the other ones, they might still respond to things like Nulo limited ingredient or the Turkey Instinct or something like that, or the Merrick limited ingredient. They may still respond to that if their issue is with a grain or a carbohydrate source. So um, but those are some options. The prescription diet trials, and then sometimes I'll do a budesonide or prednisolone trial and see if it works. Doesn't mean the cat has to be on it forever, but if they absolutely won't do anything else, I have definitely done that before just to see if it helps. Food responsive enteropathies. Diet trial of at least 2 to 4 weeks for each new food. 6 to 8 is ideal, but you should see an improvement within 4 weeks. Adverse food reactions or allergies, again, limited ingredient, novel protein, hydrolyzed, or highly digestible. Highly digestible, I think I have a list here. So prescription, Royal Canin SP, Rabbit, I think is mostly what we do. The Science site has DD. I haven't used that recently. Blue Buffalo has alligator. I use Rain the most. Rain Clinical Nutrition, Rabbit, or Kangaroo. There's different textures, there's kibble, there's a freeze dried, there's a stew and a pate. They have lots of different options. Again, over the counter. Oh, still in chewy. I forgot about that one too. It's a freeze dried that you can mix with water, warm water, and get them used to eating that too. Or if they like it dry, that's fine too. My cats like it either way. Hydrolyzed. So my problem with hydrolyzed is cats don't like it, and but it's fine if you can get a cat to eat it. Great. Uh, Blue Buffalo, and Hills ZD are the only two that have wet food. I have a very hard time putting a cat on an all kibble diet because I think they all need wet food. So if we do a hydrolyzed, those are the two that I do: is the ZD or the Blue Buffalo HF. I think a lot of people still have luck with the Royal Canin HP or the Ultimino or the Purina HA. I just don't like that there's no wet food. The protein sources are soy, chicken, salmon. There is a percentage of cats, according to this study, that still may respond to that protein source. So say a cat has a chicken allergy, and then we decide to put it on ZD, and it has hydrolyzed chicken in it. There is a percentage of cats that are still going to respond to that broken down protein, or if they have a soy protein and we pick one with soy, or the salmon. So in this study, it was not in vivo, it was ex vivo, but seven uh, 7 out of 9 cats still had an interleukin 10 response to the basal. So they were on cat chow. So 7 out of 10 cats had a response to the cat chow. Three out of 9 cats still had a response to the hydrolyzed chicken and soy, because cat chow has, I believe, both. So of those 7, three had still had a reaction. So it can still be an issue. And I think that's probably why I go to the selected protein a little bit more, the novel protein usually first. And it seems to be more palatable. Everybody's different. Everybody has their 2 cents to put in on that, I'm sure. Highly digestible. So Royal Canin, GI, fiber response, the regular or fiber response depends. If they have a lot of hairballs, I think the fiber would probably be better. ID and biome, we use ID as well, and haven't used the biome a lot, but I usually use the Royal Canin products. Nothing against ID or biome. In one study of 2 prescription GI diets, one of the diets showed 63% reduction in the vomiting by week 4. I couldn't figure out which ones they were because they didn't tell you which therapeutic diets they were in this study. I tried to look them up by the ingredients, but I was not successful. But there was no change in fecal score. So 60% reduction in vomiting. I mean, that's better, but I think it could be better. We could do better. So our first line of diagnostics: first, stop the vomiting. We want to stop the vomiting. Can use Serenia or ondansetron, make the cat a little more comfortable while we're trying to figure this out. Like I said, do the retroviral testing, fecal O&P, or the PCR if there's diarrhea accompanying it. Do the blood work, CBC chemistry, T4 UA. FPL is kind of my little secret weapon. You can add that on to whatever panel if you're doing IDEX or Antec. And a lot of times, if you just cannot convince this owner that there's something wrong with this cat, I add on the FPL, and sometimes it's high. And it gives me that one little thing where I can say, look, something's wrong. We need to look. We need to keep going, because a lot of times they just won't believe me. So this cat obviously in the picture had a needle foreign body. But yeah, I just thought it was a cool exercise, so I put it on there. So Corona titers, you can always add that on too. If you think maybe there's FIP, it might be able to be supportive if you get a high titer. And then radiographs plus or minus contrast. So this is what I consider first line stuff I can do today, right now. And this is what we can rule with the first line diagnostics, which is great. That's a lot of stuff. So we talked about the behavior, we talked about medications, we've done blood work to rule out the electrolyte, the hyperthyroid, the hypercalcemia, yada, yada. So we get through that. It's all fine. Now what? Now we have our secondary diagnostics. So we can do an abdominal ultrasound, we can do a GI panel to look at TLI, PLI, B12 and folate. We have fungal assays we can do, and then we can do some fine needle aspirates if we need to do that as well. When I do my abdominal ultrasounds, these are all the things I'm looking at: liver, gallbladder, and bile ducts, kidneys, adrenal glands, spleen, urinary bladder, the GI tract, and some lymph nodes. This is what I'm looking at specifically in the GI tract. So I start with the stomach and the pylorus, go to the duodenum, find the papilla, look at the pancreas and the pancreatic ducts, the jejunum, ileum, ileocecal colic junction, cecum and colon, and then all these lymph nodes. I might not find them all, but I look for them. They're there somewhere. And here's the normals. And again, we're visiting this ultrasound image of the stomach, duodenum, jejunum, ileum, and the cecum and colon. They should be around 0.2 to 0.25, the ileum up to 0.28. And then for secondary testing as well, we have histoplasmosis, urine antigen testing. I live in a place where histoplasmosis is endemic. We do see it, and sometimes it looks like GI disease. So you can do a histoplasmosis urine antigen test. We send it to Mira Vista Labs, get it back in about a week. It's pretty accurate. I've never gotten a result that I questioned, which is helpful. And then the GI panel. So we're looking for EPI, pancreatitis. The cobalamin will indicate distal small intestinal disease, and the folate usually indicates proximal small intestinal disease. So if you're looking on ultrasound and all you see is a thickened ileum and you have a low cobalamin, great. That's definitely helpful in saying you're on the right track. You might also get a low folate. That would indicate that maybe there's disease in the duodenum, whether you saw thickening or not. High folate can indicate bacterial overgrowth. Don't usually pay much attention to that, but just something to mention. Okay, detour. We're gonna go on a little field trip because I mentioned histoplasmosis. So in Texas, I'm down in Houston. We have it. There's lots of places in our country and other countries that do also have histoplasmosis. So I want you to be on the lookout for it because it will mess stuff up. It will drive you crazy. So just a brief, is histoplasmosis endemic in your region based on that map? While that's happening, do I administer ondansetron subcutaneously to cats? I do. My dose is, it's 0.2 mg per kg. I make it easy. It comes out to the same volume dose as Serenia for ondansetron. Yeah, 0.2 mg per kg. Could I bring the map back? Yes, ma'am. Here's the map. Okay. 51% yes. Oh, yay. Okay, I'm not alone. 49% no. Okay. Clinical signs, much clinical signs. Fever, yes and no. Weight loss, yes and no. Lethargy, yes and no. Anorexia, same. Dyspnea, same. Coughing, same. Vomiting is on the list, as is diarrhea. The last couple histoplasmosis cats we saw did not have dyspnea or coughing. did not have a fever. I saw two that had vomiting. Physical exam, you might see uveitis, splenomegaly, renomegaly, might be palpating the enlarged organs. You might see, I've never seen a skin lesion, but it can happen. Joint swelling and lameness, I have seen that as well. Non-regenerative anemia, thrombocytopenia, leukocytosis, hypoalbuminemia, hypercalcemia, elevated liver enzymes. So you may see all of that on the CBC and chemistry. You can also see azotemia. I think that's all. Cytology. There's some different ways to get it. You can do a lung FNA. I know that's a little extreme, but if you're not finding it, you can do it. Skin lesion impressions, conjunctival swabs, possibly lymph node, liver, spleen, and kidney FNA. I've never gotten one on an FNA, but it can happen. Radiography, 90% will have radiographic lesions, whether that is in the chest or musculoskeletal, organomegaly. There's a lot of different presentations that you can see. Even if they do have GI disease, if you take radiographs of the chest, you may still see signs in the chest without the coughing and dyspnea yet. Ultrasonography. We do a lot of ultrasounds. You can see hyperechoic liver parenchyma. You might see ascites, splenomegaly with a hypoechoic parenchyma, large kidneys with an indistinct corticomedullary junction, just like this one up here. So for this cat, the size of the kidney was fine. The creatinine was elevated, and this just haziness right here was a little weird. Mesenteric lymphadenopathy and intestinal thickening. Sometimes you get nothing but intestinal thickening, or maybe lymphadenopathy with that. The treatment for histoplasmosis, itraconazole is usually my go-to. It comes as itrafungal. It's a lot of liquid for an adult cat, but it can happen. I would not compound this as a liquid because of the inconsistent dosing and the potential for toxicity for itraconazole. You can use fluconazole as well. If it's very severe, you may need amphotericin B, lipid complex. Posaconazole is, I think, being used a little more frequently as well with some luck. You may need a combo of itraconazole and amphotericin. That's ideal, especially if the cat's really sick. Thank you for indulging me in this tour. In this detour, we will go back to chronic vomiting. Yeah, we talked about that. Okay, so fine needle aspirates. We do these a lot. All the organs, lymph nodes, spleen, liver, masses, gallbladder, kidney. The way I do it, ultrasound guided. Usually get better results with a 22 gauge, 1.5-inch needle. I use like a peck and twist instead of just, I just peck it and twist it while I'm doing it and then redirect it without the syringe attached. So just the needle. If you think you might need suction, it's something that might not exfoliate well, by all means suction, but I usually don't. I get a little bit less blood contamination that way. What we're looking for. So say we do a fine needle aspirate of a lymph node and we get a bunch of lymphocytes and or just an increased population of lymphocytes, and the pathologists don't know what to do with that. Like we're not going to call this but you can add on immunocytochemistry for that, for CD3 to identify a T cell lymphoma or an increased population of T cells in that lymph node aspirate, or CD79A. Some labs do either that or 20, and that will identify B cell lymphoma. Coronavirus, you can do an mRNA of the M gene. I know Auburn University does it. There may be more labs that are starting to do that more frequently. So if you think this might be coronavirus, it might be FIP, you can send it or have the lab send it to Auburn. You need a lot of cells for immunocytochemistry. So if you're gonna get a lymph node and you're like, I might be able to do this ICC on it, get 8 slides because you do need a lot. You can't just do 2 slides and some lymphocytes. It has to be a good sheet of lymphocytes, and you have to have multiple slides to do that. They can also do PAR testing on cytology. Again, you need a good population of cells, so get a lot of samples. It's not as accurate for B cells, but it's definitely great for T cell lymphoma. Fine needle aspirates of the intestines. It has been reported that it is possible to get a diagnosis from a fine needle aspirate of the intestines. In this study, 58% had successful sampling. So they tried it in 152 cats, and only 58% of them, they really got a good sample that they could see anything. In 30% of those cats, getting the lymph node at the same time was helpful in nailing down the diagnosis. There was a lot of discrepancy between cytology and histopath. 8 out of 17 did not agree. The takeaway from this, from what I can see from this study, is you can confirm it's neoplasia, but you cannot rule it out. So if you do a fine needle aspirate of the intestine and you get a clear cut, oh, this looks like lymphoma, then great. But if you don't get that, you cannot rule out lymphoma. The method for this was, if you're looking at the intestine end on, you're going all the way through the lumen to the other side of the small intestine and poking that and doing the peck and twist and coming out. You can see the paper for the more details. All right, so slowly and surely ruling all this stuff out. Now we just got some of the more advanced stuff to go. Tertiary diagnostics, endoscopy, laparotomy for biopsies, endoscopy. When we do endoscopy, I usually do upper and lower. I try to get the ileum and maybe the distal jejunum through colonoscopy, but when you go through the upper GI, get duodenum and proximal jejunum. Also collect bile for a bile culture and cytology. If there are enlarged lymph nodes, I will get an FNA of those if I have not already. And then biopsies of the mucosa, submucosa, and I try to get as deep as I can. I don't always get through to the muscularis, but do the best we can. It does miss everything in the middle, unfortunately. So you can get the proximal and distal jejunum, but you're going to miss everything in the middle. It's better than nothing, and we have definitely got a lot of good diagnoses on that, but that's the downside to endoscopy. Laparotomy, couple of things to focus on is culture and biopsies. Culture, I get a bile culture, I do get a piece of liver for culture, and then it's just kind of my weird thing that I do is I do get a swab, a culture swab of the abdomen after everything's biopsied, I've flushed everything, I get another sample and I send that for culture, only because it has saved me before when I did that and the cat developed septic peritonitis 3-4 days later, just as the culture was getting done, checked the cat and just yellow pus just came pouring out of it. And he wasn't responding to antibiotics. Come to find out he had an antibiotic resistant bacteria that was only sensitive to chloramphenicol. Never would have put the cat on that. But ever since and the cat was saved because we had the culture results. So ever since then, I've always done that. Never happened again though. So, biopsies, liver, pancreas, all the sections of the GI tract, duodenum, jejunum, ileum. You can get a couple jejunum and the lymph node. Endoscopy, what are we looking for? Erosions, hyperemia, friability, masses, hairball or trichobezoar, Physoloptera. Might be able to see some wormies. That would be fun. Same for the colonoscopy. I mean, we're looking for, oh, that was gastroscopy, apologies. So we're looking at the stomach right there. So endoscopy in the intestines, pretty much the same thing. You can also see motility, masses, polyps, the granularity of the mucosa, and then any strictures as well. Surgical biopsies, again, lymph nodes, liver, pancreas, stomach, duodenum, jejunum, ileum. As far as culture is concerned, there is a more advanced fluorescent staining that they can do. fish to identify bacteria within the liver. If the culture comes back and you really think, oh, this has got to be an infection, they can do a fish fluorescent in situ hybridization on the liver, intestines, or the pancreas, and then FNAs as well. Same thing with histopath. You can do IHC for these markers, and coronavirus pathologists should recommend them if they think it would be helpful, and then PAR testing as well. All right, we've ruled everything out. Now we go on to the treatment. We get the histopath results back and we need to treat. So cyclosporin, pred, budesonide for inflammation. All of those are helpful. B12 and folate as needed. The diets, limited ingredient, novel proteins. So say we get a small cell lymphoma. How do we treat that? Prednisolone, chlorambucil is usually where I start. The prednisolone I try to get down to as low as I can, maybe 1 mg per kg, along with the 2 milligrams every other day of the chlorambucil. You can get chlorambucil compounded. I really love to get it, not love, I prefer to get it as capsules or tablets just so the dosing is accurate. You can get it as a liquid, but it always just makes me a little nervous. And then the B12 and folate as needed. Intermediate to large cell lymphoma, there's a couple different protocols, CHOP, COP, and then the CMOP, PRED. Rescue, you can do in the clinic is the prednisolone and lomustine. We do that a lot. It does buy the cat sometimes a few months, so the owners can kind of come to terms with it. Really, the CHOP protocols only get us 6 to 9 months anyway. Prednisolone alone is around 1 to 2 months. Carcinoma and mast cell tumors, surgical excision recommended 4 centimeter margins for carcinomas. Showed 7 out of 9 with complete resection, so I do 5. Seems safe. Tesseranin and phosphate, that's Palladia, 2.5 milligrams per kg. That might be helpful for carcinomas. It's probably not going to make it go away, but it'll stop the growth. It's an anti-angiogenesis medication. In one study, there was a 32% complete response. Didn't go away, just response of clinical signs. These are 8 of the listed cats we've seen recently. So renal, gastric, intestinal all received CHOP. They lived 6, 3, and 19 months. With pred and lomustine, these 2 were gastric, and in the liver, only 2 months. Intestinal with pred and lomustine, 7 to 13 months. So that's not too bad. Okay, we'll come back to questions later. I want to make to make it through these cases for you. So Ms. Ziva, she's a 7-year-old female spayed domestic short hair. This was my favorite history I've had in a while. Become ill with vomiting every several months, gotten worse over time. Last Friday was about a vomiting. She went limp. Her abdomen was painful and she lost control of her bowels. The time prior, 6 months ago, she was not vomiting, but she acted as if she was trying to vomit or choking and stopped breathing. I had to give her the Heimlich maneuver, but nothing came out and she started breathing again. My mind. So this is a vasovagal response to vomiting. She was seen elsewhere. They put her on I don't think they were sure what was going on, so they put her on the GI diet, the ID, Metro, Doxy, Serenia, B12, and gave her a dexamethasone injection. We did all the things on her chemistry. The only thing that was a little off was her ALT was slightly elevated. Fecal was negative. She was a little dehydrated, and she had some gas in her stomach, probably from vomiting and swallowing that. We did an ultrasound, was normal. GI panel was normal. Treated her with Rain, clinical nutrition kangaroo. Continued the Serenia. 2 months later, vomiting stopped. No more vasovagal episodes. 1 year annual, no vomiting. And she's been fine ever since. So that's an easy one. Okay, number 2, Scout. 10-year-old female spayed domestic short hair, vomiting food 1 to 2 times per week for the past year plus. No other clinical signs. Good body condition, but her weight has dropped 1.5 pounds. Everything on her labs was normal except that FPL. That little FPL is just a tad over normal. So that was what the owner needed to see to move forward with this. We did an abdominal ultrasound. The duodenum was a little bit thickened at 0.28. Remember, normal is 0.25 and less. Jejunum ranged from 0.19 to 0.34. The upper range is like 0.22 to 0.25. Ileal thickening, mildly enlarged lymph nodes, modeled pancreas, so evidence of pancreatitis, and the GI panel was normal. So what did we do next? Endoscopy. That mucosa was really friable. It just scraped right off when I passed the scope in there. Distal ileum was edematous, colon was edematous and hyperemic, friable. And her, surprisingly, everything was mild, but it was lymphoplasmacytic and eosinophilic enteritis. We did the IHC and the PAR testing. It did not confirm neoplasia, so that was fantastic. Treatment compliance, unfortunately, was inadequate. They kept changing everything. They would not feed her the diet that we recommended. Kept her on Cerenia and prednisolone. Tried to get it down to the lowest effective dose. However, every time she'd try to reduce the dose or take her off of it, the pancreatitis would come back. She'd start vomiting. It would this vicious cycle. So we had to just keep the cat on prednisone and keep her there forever. And she's doing fine. Okay, last one, I promise. Cezanne, 8-year-old, domestic short hair. House soiling was one of the issues. House soiling, polydipsia, hyporexia, vomiting clear fluid twice weekly with no pattern. I'm sure you've seen some of these train wrecks before. Was taken in from outside a year prior. Since brought in, he's lost 2 pounds, has a Gallup heart rhythm, muscle condition score B or would be 2 out of 4, and then mild skin tinting. And this is Cezanne with his chopped ear in a hot dog costume. His blood pressure was a little elevated at 170. Hematocrit was slightly low. He was azotemic with the iris stage. Was at 3 out of 4. Hypokalemia. FPO was 14. The high normal was 4 or 5. ProBNP was 82, which is fine. And the low specific gravity. That's everything in writing. I know I'm cruising through this, so I apologize. I just want to have time to be able to answer your questions. Chronic kidney disease. This is how I started treatment for him. We addressed the kidney disease first. Fluids, potassium, low phosphorus diet, OTC diets. For the pancreatitis, buprenorphine. We did a low, like a 0.02 mg per kg oral transmucosal every 12 hours since he has kidney disease. Some of these cats you have to actually go down to 0.01 mg per kg because they just hold on to it, they don't clear it. And then Cerenia orally every day, Mirataz transdermal every day. His response. So post-soiling continued. Creatinine didn't get better. Appetite improved, but he continued to lose weight. Vomiting continued once the Cerenia was stopped. So we decided to go on. You'll recognize this kidney up here. TLI, folate were normal, PLI high, cobalamin low. So even though the low range on the GI panel says 2 something, I consider everything below 800 not normal, or 800 or lower not normal. So we started supplementing with that. Moderate small intestinal ileal thickening, lymphadenomegaly, bilateral loss of renal corticomedullary delineation, normal kidney size. Urine culture negative. It was active though. There were red and white blood cells in it, no bacteria. I did not believe it, so I actually ended up getting a urine sample directly from the kidney. Used a 1.5-inch long needle and obviously was under sedation. Put the needle in the pelvis of the kidney, got the urine, and cultured it. Nothing. So what are you thinking? Ponder that while I tell you what we did. Patient treated with pred B12 Mirataz continued to decline and was euthanized. So did not get better, continued to get worse. What would your presumptive diagnosis be based on what we see? Yeah, neoplasia 64%. That was mine too. I also thought it was neoplasia. It's not. I don't know if you can see all that. I did postmortem on him because I just could not figure it out. It was histoplasmosis. This was my learning case as I moved to Texas and learned all about histoplasmosis. um, yeah, so he had disseminated histoplasmosis. No lung lesions. He did have chest X-rays. Nothing. No coughing. No nothing. So my takeaway for y'all is vomiting in cats isn't normal, even hairballs. So let's educate the clients about it. Let's figure it out. These cats don't need to vomit. Uh, if they keep vomiting and we don't address it, bad things can happen. It can progress. It can lead to cancer. Chronic inflammation is where cancer starts. So addressing it early prevents our catastrophes. So thanks so much to everybody for hanging in there. I know I made it right on time. um, I appreciate it, and there's lots of questions. No, I see. Had a fever. No, did not have a fever. I hope this helped a little bit. What are your thoughts on cats that chronically ingest and vomit plant material? No, they just like it. They just like the plants. They like the grass. They're not trying to make themselves vomit. They just like it. Um, I've never used Panic Quell off label. I would be interested to hear if anyone has. There is a list of low phosphorus OTC diets on catinfo.org. It is a little bit outdated, but that's what I use. For the case two example of pancreatitis and on prednisolone, does the cat become diabetic as a result? Um, it happens. Sometimes they do, but I don't usually find it. If I can keep it at 2.5 milligrams a day or every other day, I don't usually see them become diabetic. It's usually the 5 milligram per day and up. Or if they're really obese or overweight. If they're underweight, not much. If that's the case, you can always switch them to, if you're concerned about it, you can switch them to Atopica. I see you're using 8 mg per kg Serenia Q24 for 14 days. Um, that's typical. It usually just comes out to, oh, it's not 8 mg per kg, it's 8 milligrams, 8 milligrams total. So it's a half of a 16 milligram tablet. Apologies if I wrote 8 mg per kg. It should be 8 milligrams total. What's your ideal treatment protocol for pancreatitis? Serenia, Mirataz, buprenorphine. If I think there's GI, I'll give them an injection of dexamethasone, 0.5 to 1 milligram. Do you ever go back to do diet challenges? Sometimes. Clients don't usually want to do that though. OTC foods for food trials. I use um, Instinct limited ingredient rabbit, Nulo limited ingredient. I think there's like a duck, but I go to the Instinct first if clients are willing to pay for it. You're right. Most owners don't go for the advanced diagnostics. Um, if you do the basic stuff and it's all normal, um, I'm not above giving a cat a depot injection. I didn't say it. Don't. Don't report me. Don't report me. Um, I have had some um chronic hairball cats where the clients don't want to do anything, they don't want to treat, and like, just let me give them a shot and see what happens. And I'll give them like a uh 5 to 10 milligram methylprednisolone injection. Say, okay, I'm not going to do this again. This is just a test. I'll give them an injection and see what happens. If the hairball vomiting stops or calms down, then you can at least say, look, it's probably inflammatory. We need to do something. Or if everything comes back normal, just do the diet change. Just try the diet change. Um, Give them some Serenia for 2 weeks, change the diet and see what happens. The basic stuff is usually what clients want to do first. That and the fiber for hairballs. Use Denamarin if it's antioxidant. I haven't for pancreatitis. For hepatitis, maybe, or cholangiohepatitis, yeah. Sucralfate, I prescribe it if they're vomiting like a pink tinged or blood. If you think they might have some esophagitis. For pancreatitis cats with owners are unwilling to continue with ultrasound, do you switch to a GI diet? Yeah, I've done that. Sometimes it works. Um, yeah, if it's a hairball, the GI diet's probably helpful. If not, then I would do a limited ingredient diet, normal protein. Um, do you ever use capromelin? We've used it before, the Allura. Uh, um, Cats hate it, they drool, but if the Mirataz doesn't work, yes, we'll use that too. Histoplasmosis it's better as a urine antigen test. It's excreted through the kidneys, so you pick up the antigen on the urine pretty well. FMT, we do fecal transplants on cats that have chronic diarrhea. I've not used it in vomiting, but the animal biome does have an FMT oral capsule that you can try. Laxatone, yeah, I didn't talk about that, did I? A lot of owners love Laxatone. I just don't. It's like giving your cat flavored Vaseline. Like, sometimes it works. Some of them swear by it, and if they do, yay. But I don't know. I don't routinely check toxoplasmosis before cyclosporin. I've not had an issue with it, but um, it's definitely not a bad idea. It's not a bad idea, but I don't know. Can cats vomit every day due to stress, especially if it's around the time a new cat entered household? Yeah, maybe. Stress can cause inflammation too, so it can incite inflammatory responses, but um, it's possible. Yeah. Do you ever have diabetic chronic vomiting pancreatitis cats on prednisolone? Oh, yes. It's very hard to manage. Budesonide helps. You can switch to budesonide um, and still have their vomiting controlled. That usually has a little bit less effect on blood sugar. Or you can switch to cyclosporin. Vomiting food anywhere from 5 minutes to several hours after eating. Blood work and rads all normal. Clinically normal, other than vomiting a couple times a week. Various diet changes. Biome, ZD, no changes. Any suggestions? Um, if it's a young cat, I'd probably try limited ingredient novel protein or a hydrolyzed diet. 2 weeks of Serenia. If that doesn't work, then I mean, it's not wrong to do a steroid trial, run some B12. Mm, yeah, I'm not above doing a steroid and B12 trial for people that don't want to do the stuff, especially if the cat is otherwise healthy, not obese. Um, or you can do cyclosporin too. But yeah, I would do a steroid try. I don't usually go to immunosuppressive doses of steroids because that's definitely when you're going to make them diabetic. If they don't need it, then great. But if it's really bad and they need it, then obviously give them steroids. Liquid Serenity, I'm not sure what that is. How long are you comfortable giving B12 if they decline